Good afternoon, everyone, and welcome to our Delivering a Net Zero NHS launch event. We're really excited to launch this competition in partnership with the Greener NHS program and supported by the AHSN. I'm Fanny Burrows. I'm leading on the SBRI Healthcare program, and I'm joined today by other members of the SBRI Healthcare Program Management Office supporting the competition. And we also have some great speakers today to give you some insights on the competition, on the challenge, as well as the support that is available from the AHSN. So for the agenda today, we will start with an introduction about the SBRI Healthcare program and overview of this particular competition. And then we'll be joined by three amazing speakers. We'll have Dr. Nick Watts to give us some information about the NHS Net Zero ambition. And then we will be followed by Dr. Cliff Shelton, an anaesthetist that will discuss about anesthetic gases and particularly around the challenges around the use of the nitrous oxides. And finally, we will have Alexandra Hammond that'll be discussing about sustainable procurement and the supply chain, but also the relevance of it to the overall net zero ambition. You'll have an opportunity to ask questions to our speakers during the first session through the Q&A box, and we'll answer some of these questions live. Following this, we'll have Cathy Scott that is coming from the Yorkshire and Humber AHSN, and she'll talk us through the AHSN Network and their role in supporting innovation. And then we will be followed by the Program Management Office to give you more information about the competition assessment process, but also how to apply to the competition. And then we'll have the final Q&A session at the end for questions related to the program, to the application, but also about the AHSN. So if we could move on to the next slide, just a very quick housekeeping note. I think we've already gone through it more or less, but please do put your question in the Q&A box that you'll see on your screen. And we'll answer your questions in writing or live during the Q&A sessions. We will upload the slides and a recording of this session on our website for you to be able to access it. But there's also a lot of information that you can find on our website. And for example, you can find a challenge brief about this particular competition and further guidance as well. But now, without any further delays, what I'd like to do is to move on to our first speaker, and I would like to introduce you to Randa Tajdin, a senior program manager in the innovation team. And Randa is going to give you some information about the SBRI Healthcare program and the scope of our net zero competition. Over to you, Randa. Thank you.
Thank you, Fanny. Good afternoon, everyone. I'm Randa, and as Fanny mentioned, I'll be giving an overview of the program today and our new competition call. So next slide, please. The SBRI Healthcare program is a program that is funded by NHS England and NHS Improvement and is supported by the Academic Health Science Network. And it runs yearly themed competitions to address unmet needs within the NHS and supports the development of innovative technologies through stages of development which are typically hard to fund. And the aim of the program is to use the power of government procurement to bring together business, health, technology, and government partners to address major unmet health needs and facilitate the introduction of innovations into the NHS. So the program offers an excellent opportunity for businesses, especially early stage companies, to develop and demonstrate their innovative technologies. And the key objectives of the program are to improve healthcare, increase NHS efficiencies, allow the NHS to get access to new technologies, and to support economic growth. Next slide, please. As I mentioned, the SBRI Healthcare program is supported by the Academic Health Science Networks, which consists of 15 networks across England that were established by NHS England in 2013. And they were set up to support the spread of innovation and to improve health and generate economic growth. And each Academic Health Science Network works across a distinct geography, serving a different population in each region. And we have Cathy from the Yorkshire and Humber Academic Health Science Network with us today, and she'll be providing more information on the AHSNs and what they do later on. Next slide, please. The program runs a series of health-related competitions, which results in fully funded development contracts between the awarded company and the NHS. And although the program is aimed at SMEs, any size business is eligible to apply, including NHS organizations and higher education institutes, as long as a route to market has been demonstrated and as long as the organization is based in Europe. And the way the program has been set up is by taking a two-phase development approach. So phase one proposals concentrate on research and development, which will significantly contribute to proving the scientific, technical, and commercial feasibility of the proposed project. And if successful at phase one, projects can then move on to more detailed product development at phase two. And phase one awards are worth up to £100,000 and last for 6 months, whereas phase two awards are worth up to £1 million and last for a year. Next slide, please. The key things to note are that unlike many research and development funding programs, which offer grant or match funding, SBRI contracts are 100% funded, and funding covers a wide range of costs, including labor, materials, subcontract, capital equipment, and other costs. The IP ownership rests with the awardees, and awards are milestone driven and have a light touch monitoring and risk-based approach. Next slide, please. Since the program was created, it has continued to deliver value for money and has supported a strong portfolio of innovative medical technology solutions. And to date, we've supported over 220 products and have invested over £99 million into those technologies. Next slide, please. To give you a snapshot of the portfolio, we had over 50 companies generating sales in the NHS following their funding. We've had around 66 generate commercial revenues, of which 29 have exported products internationally, and over 290 million has been leveraged through private investment, and over 400 collaborations have been established. So quite some good metrics that we're proud of. Next slide, please. So the SBRI Healthcare program supports a range of different types of innovations, including devices, digital, diagnostics, and even services. And to give you examples of some companies we've supported, we have Open Bionics, who developed Hero Arm, which is the world's first clinically approved 3D printed bionic arm. And following their SBRI funding, they were able to raise £4.6 million in Series A funding, carry out a world first clinical trial, which led to their product being launched in the US, the UK, and France. We have Alstone Medical, who developed Lucid, which is a lung cancer detection diagnosing tool. And following their funding, they were able to attract global interest and raise $50 million in venture capital. MyM Health is a web-based self-management program for COPD patients. And following their funding, they were able to get onto the NHS Innovation Accelerator program. And then finally, you have See the Signs, which is a digital tool for GPs to assess patients during consultation. And the developers were able to get regulatory approval with their funding and spread the adoption of their technology across a number of CCGs and cancer alliances. Next slide, please. So that was just an overview of the program itself. As mentioned earlier, the program runs themed competitions. And one of the themes for our competition this year is delivering a net zero NHS. So in 2020, the NHS became the first health system in the world to commit to getting to net zero carbon. But shifting to a net zero health system presents unique challenges, and meeting this commitment will involve changing how care is delivered without compromising on the quality of care. And although there's been significant progress in the adoption of new tools and technologies in the NHS to meet net zero, there's still plenty of work to do. And if we want the NHS to reach its goal of becoming the world's first net zero carbon health system, we need to address some of the continuing challenges that are being presented. And this will involve the adoption of technology to do so. So this competition seeks to address the challenge of meeting those NHS net zero targets, considering the systemic complexity associated with meeting those challenges and the impact it would have. Specifically, we're seeking innovations that have considered challenges associated with supply chain and the impact on carbon reduction, and the applicants will be expected to address both these areas. So when thinking about the supply chain, we're looking for innovations that have considered product lifecycle and procurement. So for example, we'll be looking at whether you've considered where you source your materials from and what you do with them after they've been used. We'll also be looking at whether you've considered the methodology and framework to measure reduction in carbon emission, both quantitatively and qualitatively. And these are important because the NHS has a commitment to move towards sustainable procurement by 2030. So they're going to be interested in the upstream and downstream effect your innovation will have on the sustainability of clinical pathways. Next, please. So that's some of the criteria of the competition call. But in terms of the challenge areas, we're looking for innovative solutions that will reduce carbon emissions through 4 key areas. And those are reducing emissions from care miles, reducing emissions from surgical pathways, reducing nitrous oxide emissions, and developing tools to support low carbon decision making. And to give you examples of the types of innovations we're potentially looking for in each of those areas, in reducing emissions for care miles, that could be innovations that could move patients away from hospitals and support more local resources. In reducing emissions from surgical pathways, those could be innovations that provide alternatives for tools that are used in surgical procedures that are associated with high carbon emissions, for example. In reducing nitrous oxide emissions, we could be looking at innovations that provide low carbon alternatives in emergency or ambulatory care, for example, use of anesthetics. And then in tools to support decision making, those could be educational type tools that could potentially empower clinical professionals to make greener choices. And we're joined today with some experts in the field who are going to speak more on these challenges and the types of solutions that could potentially address them. But if you would like to find out more about the competition scope, you'll be able to find more information in the challenge brief, which will be available on our website. So do please check it out. Next slide, please. Just a final slide from me is some key dates. So we're opening the competition on the 13th of July, so you'll be able to submit applications from then. The deadline to submit applications will be the 24th of August, and applications will be assessed in September and shortlisted and taken to panel in October, and we're expecting outcomes of awards to come out by November. And that's all from me for today, so thanks for listening. I'm going to pass on to Fanny, who will introduce our next speakers. Thank you.
Great. Thank you very much, Randa. That was a great introduction about the program. Thank you. Now, I would like to introduce you to Dr. Nick Watts. Nick is the Chief Sustainability Officer at the NHS, and is responsible for its commitment to deliver a world-class net zero emission health service. He also leads the Greener NHS team across the country. Nick is a medical doctor licensed in Australia and in the UK, and is trained in population health and public policy. Now, prior to his role in the NHS, Nick worked internationally as the Executive Director of the Lancet Countdown and the Lancet Commission on Health and Climate Change. And he also has focused on engaging the health profession on the links between public health and climate change, having founded the Global Climate and Health Alliance and the UK Health Alliance on Climate Change. Welcome, Nick. Thank you so much for joining us today. And over to you.
Fantastic. Hi. Hey, everyone. You can hear me?
Yeah, perfect. Thank you.
You can understand my accent. Very Australian. Good. Thank you very much. Thanks for having me here. That goes without saying. What really does need to be said, though, is thank you to everyone who has pulled this competition together. To SBRI, to our friends in IRLS, Innovate UK. It's so important. partly that we see the NHS respond to this challenge, this climate crisis, deliver a net zero healthcare system, but so important that we get the innovation pipeline right as we do that. And that doesn't begin in 2044, 1 year away from when we're hitting that last mile problem. It begins today, right? So net zero, the NHS, we are big. Why would the NHS care about climate change? Very, very simple. We were founded with a admirable principle, admirable goal, deliver high quality care for all now and for future generations. It was quite a while ago, the 40s, 1940s. Since then, and where we are today, it's pretty clear. Now, you can't do that. You cannot deliver a high quality level of care for every population, everyone in the population now and future generations, unless you respond to climate change. Can't be done. The NHS has its net zero goal because we know that it aligns perfectly with the work that we want to do, because we've had a good crack at it for the last 10 years, depending on the scope you're looking at. 26, 62%. Either way, some impressive reductions, well ahead of what you might expect from under the Climate Change Act. We're pretty proud of that. Wasn't done by the people necessarily on this call. It was done by 1.3 million clinicians across the country. What we're even more proud of is, as that happened, as the NHS already reduced its emissions over the last decade, we gathered some case studies, we gathered some summary information, we gathered the sort of overall sense of what the effects of that were. It becomes very, very obvious. As you reduce emissions, as you start to deliver that low carbon healthcare, you improve health. Cleaner air, healthier diets, more livable cities, more efficient healthcare systems, care closer to home, right? The synergies there are pretty much everywhere you look, pretty much everywhere you look. The other thing we learned is, God, there's a heck of a lot of energy ready to be unlocked here. Every year we go out, we ask our staff, hey, what do you care about? What do you really want to see the NHS do more of? The answer every year, coming back again and again and again, I want to see the NHS work in a more environmentally sustainable way. I want that because it is embedded deep in the DNA, deep in that Hippocratic oath I took as a clinician, primum non nocere. That's what gives us, I think, the energy to, feel like we can take this sort of thing on. Energy is good, ambition is good, but I think we're also proud that we have a decent plan. A net zero strategy published in October last year, something that we have been busy working away at. That has in it some things that we just know how to do. We just know how to do a lot of what you might want to do to decarbonize the estate, the materials you require, the superstructure changes, the operational changes that you might put in place. That stuff, fair enough. It has some things in there around low carbon transport, around electrification of the transport fleet, the air pollution reductions, the health benefits you might expect to see from that. Good. But then there is a lot in there that we just don't know. We just don't know how we're going to get the entire way to net zero. And that, I think, is where partly we'll hear from Alex in a bit. Our work with our suppliers in the supply chain, in the procurement world, is so critical. Within the decade, the NHS will no longer purchase from anyone that does not meet or exceed our commitments on net zero. Anyone that doesn't believe me should look very, very seriously at my face and how grumpy I can get. We really mean that. We really mean that. We really think it's possible. So that's the long-term target. We've got to get some of that innovation ready and moving today. And I think that's what this competition is about. We've had similar successes around anesthetics, looking at this kind of work. We've had similar successes with ambulances, zero emission ambulances. And so this is the next step for us to try to provide that support, to provide that incentive, and to partner with our suppliers towards what we hope, what we know will be the world's first net zero healthcare system. Thank you.
That's great. Thank you so much, Nick. Really inspiring to hear the ambition from the NHS and from the Net Zero team in sort of advancing the healthcare system. Yeah, really inspirational. It's a great ambition. We will go through Q&A a little bit later, but if you have any questions for Nick regarding the report and the ambition, please do pop them into the Q&A box and we can go back to it. Thank you. So now I would like to introduce you to our next speaker, Dr. Cliff Shelton. And Cliff is a consultant anaesthetist at Wythenshawe Hospital and also a senior clinical lecturer in anaesthesia at Lancaster Medical School with special clinical interests, including the anaesthesia for hip fracture repair, obstetric, and emergency surgery. His academic interests include sustainable healthcare, quality and safety, and medical education. So very interestingly, Cliff is also clinical lead for sustainability for the Department of Anaesthesia at Wythenshawe Hospital and a co-opted member of the Association of Anaesthetists Environment and Sustainability Committee. On the top of that, Cliff is also currently leading the Greener Operations, which is a James Lind Alliance research priority setting partnership on sustainable peri-operative practice. Cliff, thank you for joining us today. The floor is all yours.
Okay, thank you very much. Can I just check that you can hear me okay?
Yes, we can. Thank you.
And you're going to click through my presentation. Okay, so I'll give it a go. Well, thanks ever so much, everybody, for giving me the opportunity to speak. I'm really delighted to come along and support this. And my job here today is to give you a bit of a clinician's view on nitrous oxide, which I'm absolutely delighted to see represented in this particular scheme. Can you click on to the next slide, please? So what am I going to do in the next 10 minutes? Well, I'm going to tell you a little bit about this drug, this chemical, nitrous oxide. I'm going to explain why I think we use it in clinical practice and also why I think we should stop or at least seriously mitigate the amount that we use. And I'm going to talk about this kind of triple threat of systems and clinical and emissions related stuff where I think there are things that we can do to change the way that we're using nitrous oxide at the moment. Next slide, please. So this is quite a famous painting. It might be familiar to many of you, and it's a painting of something that is called Ether Day, which was about, what is it now, over 150 years ago. And this is a painting of somebody called William Morton, who was actually a dentist and a pioneer of anaesthesia. And he used ether, which is a substance that we don't use in anaesthesia anymore, to render this patient unconscious so he could have a tumour removed from his neck. And the community of anaesthesia kind of celebrates this day as the origins of our profession. So anaesthesia has been going for, what is this now, about 170 years or so. Next slide, please. But 2 years earlier, this other chap, who was actually a colleague and competitor of Morton's, he's called Horace Wells, started using nitrous oxide. And nitrous oxide had been synthesized about 50 years prior to this. And it was initially used as a recreational drug, and it still is used as a recreational drug nowadays, as many of you will know. So Wells had been to a laughing gas roadshow, and the principle of this was that you'd breathe laughing gas and it would give you some trippy side effects. And he noticed that somebody who was at that roadshow injured themselves quite seriously, falling over and skewering their leg on a bit of broken wood. But this person didn't complain of any pain until the nitrous oxide wore off. And Wells thought, right, that's a drug for us. I'm a dentist. I'm going to start doing painless dental extractions. And he actually took this to the same lecture theatre that Morton would use ether in a couple of years later, but it didn't work very well, and he was pretty much laughed out of town. Next slide, please. But the thing about nitrous is that it's stuck with us whilst ether has gone. And you have to wonder, is this because it's quite a good drug? There's got to be something about nitrous oxide that keeps it on the formulary when virtually everything else that we were using in medicine nearly 2 centuries ago has disappeared. Next one, please. So what does nitrous do well? Well, I'm going to make a guess that many of you who are in the audience will have experienced this, possibly at the dentist or possibly when having a baby. So it's a painkiller, and it's kind of good at being a painkiller. It's fast acting, which is a good quality. If you're in lots of pain, you want your pain to go away just now. It's really easy to administer. So you administer it by breathing it in, often in combination with some oxygen, for example, in the dentist chair or in maternity. And compared to other painkillers that act really quickly, that's convenient because we don't need to put a drip in for you. So in places where you can't get intravenous access, or where you've got clinicians who aren't expert in that technique, there's a utility there for nitrous. It's really, really cheap. And for an individual patient receiving nitrous oxide, it's pretty safe. So there's not too much in the way of bad side effects. And it's really, really accessible. It's not a case of having to go to a cupboard, sign it out, get it prescribed by a doctor and so on. It's often something you just plug into the wall, plug into the cylinder, and ask the patient to breathe away on. Next slide, please. So where do we use it? Well, this has been labelled as an anaesthetic gas, and I think that's why I'm here doing this talk to you. Can you click so we can get the picture up? So anaesthesia is a place in which it was traditionally used, and it continues to be used. And I think in theatres, the latest data suggests we consume about 1/3 of the nitrous oxide that's used in the NHS. Next one, please. Then there's obstetrics, in particular midwifery-led care, and this is a drug that midwives can administer. They can make the decision to administer it. And I would say, as an obstetric anaesthetist, that there's rarely a patient who I meet who isn't on the Entonox, the nitrous oxide and oxygen mixture, at the point at which I meet them in labour. And the next one, please. And then finally, you've got the emergency department. So this is often available in ambulances, it's often available in emergency departments. And for all of those reasons that I explained, when you need pain relief, and you need it now, nitrous oxide sometimes meets that kind of clinical utility criteria. Next slide, please. But what does it not do well? Well, first of all, there's a bit of a technique thing to it. So a lot of the time when I go and see a patient who's in labour and requesting some extra pain relief, which is how we often get involved as obstetric anaesthetists, one of the things that I can advise the patient on is how better to use the nitrous oxide. So the way in which you breathe, the depth of your breaths, the pauses in between breaths and so on, make a difference. And, you know, arguably, this might be why poor old Horace Wells had such a bad time when he went to demonstrate nitrous. So it's a painkiller and it is effective, but it's got to be used in a certain way. Then there are some side effects. So it makes patients feel sick. So that's one reason why we don't use it very much in operating theatres where I work. But also it's sedating and a bit trippy. And again, coming back to the story of the discovery of nitrous oxide, an anaesthetic agent, you have to wonder if the reason that this chap fell over and hurt his leg in the first place was that he was under the influence. Then it's hazardous to staff. So it has been implicated in a number of things, including things like the rate of miscarriages amongst people who work in the operating theatres. And therefore, there's some guidelines or some regulations about how much we should be exposed to it. And in the UK, 100 parts per million in an 8-hour shift is what we're allowed to be exposed to as staff. But we're quite generous in the UK about that. In other countries, it's as little as 25 parts per million. And if you dig around in the data, you'll find that those people who work closely with patients who are breathing on nitrous oxide, again, potentially my midwifery colleagues, may be exposed to more than that, you know, if they are close to the patient in a poorly ventilated area. So it's kind of innocuous to the patients, but it can be problematic for people who are exposed to it a great deal. And then we're on to what we're here to talk about today. So it destroys ozone, and that's kind of unique, isn't it? We've got rid of a lot of stuff that destroys ozone, but we've let this stay because it's deemed to be essential to healthcare. And then it's a big contributor to global warming. Next slide, please. So how big a contributor is it? Well, this thing here, the little screenshot that I've got, is something that you can download if you've got an iPhone. It's the Association of Anaesthetists Anaesthetic Gas Calculator. And I've dialed up here a very conservative dose of anaesthetic. So I'm saying if I'm going to give an anaesthetic, I'm going to give 0.7 litres per minute of nitrous oxide as part of my anaesthetic. And if that's all I do, if I don't add in any other drugs, that would be a sort of carbon dioxide equivalent of me driving about 50 miles per hour. So for every hour of anaesthetic that I give with nitrous, even if my flows are really low, it's a bit like driving about as far as I could drive in the same time. Can you click again, please? How does this translate into the maternity or the emergency setting? Well, if you do the maths, it actually works out about 1/4 mile per breath in terms of if you're using Entonox. And so you can imagine how those numbers stack up. And if you have lots of operating theatres running, lots of people in pain, or you're a bit less careful about the amount you could administer, you can massively exceed, as an anaesthetist or as a midwife or an emergency clinician, the amount of carbon emissions you could do in virtually any other activity, including driving your car. Next slide, please. So I think there's 3 general approaches to how we can deal with this. There's systems things. In particular, we can waste less of it. There's clinical things, we can use less of it, give less of it to patients. And then there's some emissions things, we can make it a bit less polluting. And I'm going to quickly talk about what we've been doing, what we've identified already in those 3 areas, and hopefully give you some inspiration about ways in which to innovate in this area. Next slide, please. So systems, this is one of my recent holiday snaps. This is a photograph of our nitrous oxide manifold in the hospital where I work. If you could click, please, an arrow will appear. So we've got, it's reasonably modern as hospitals go, but our hospital, this bit of the hospital was built in the 1960s and it's starting to show its age. So this is a nitrous oxide manifold. It's in one area of the hospital, remote from the operating theatres, and then it's piped over to the operating theatres. And I'm sure that it's fair to say that all of the infrastructure that is there is not as good as it was when it was first put in. Next arrow, please. So you can see from this picture as well that there's lots of pipes that connect your nitrous oxide cylinders into the manifold and then onto the operating theatres. And as these things are now 50 years old or maybe older in certain cases, there's a lot of potential for these to get leaky. Now, I've not done this work yet at our hospital, but I know there are others who've done this work and identified that nitrous oxide manifold leaks are a big problem that we're dealing with in the National Health Service. Next one, please. Another thing about nitrous oxide is it's quite hard to tell how much is in a cylinder. So those of you who maybe do things like scuba diving will know that you can have a pressure gauge on the top of a cylinder, which should indicate how much gas there is in that. And that's how it works for oxygen. But nitrous oxide is stored as a liquid with a bit of vapor on top of it. And if you attach a gauge to the top of it, it tells you what the pressure of that vapor is, but it doesn't tell you how much liquid is left in there. So until you've run all the liquid out and then you start to consume the vapor, the gauge is going to read exactly the same. So you can tell how much is in there by weighing it, but you can imagine picking one of these things up and dumping it on a scale is not an easy thing to do. And so we've got these cylinders all over the hospitals, on the backs of anaesthetic machines, in manifolds and so on. And it's actually quite tricky to tell how much you've got left in one. And then the final arrow for this one, please. And so this is, you can see how this contributes to a supply and demand mismatch. And again, there are widespread reports of nitrous oxide cylinders being sent back to the manufacturer partially full and then having to be wasted. So it's difficult to align supply and demand when it comes to nitrous. And so there's a big area of wastage that we need to address. Next slide, please. So that was the system stuff. How about the clinical stuff? Well, in anaesthesia, where I work, I've been a consultant anaesthetist for a couple of years now, and in that time, I have given only one anaesthetic that involved nitrous at all, okay? And I've given hundreds and hundreds of anaesthetics during that time. And the reason I use it so infrequently is because it's a straightforward swap in UK practice. Just click for me, please. You'll see a little box of something called remifentanil appear here. And this is a drug which fulfills many of the same criteria. It's fast acting, it's a good painkiller, but it's a crystalline substance that you dissolve in some fluid and inject into the patient's veins, and therefore it doesn't have a greenhouse gas effect. So for me, I've been able to virtually eliminate anesthesia from all of my practice, simply by making a decision about a simple drug swap. In the emergency department, if you click again, it's not quite as straightforward. So there's things like speed of onset. So people tend to come into the emergency department when they're in lots of pain. In anesthesia, they tend to come in when they're expecting an elective operation. So I don't need to be quite as quick about it as my emergency colleagues. Also, you're getting a drip, you're getting a cannula in your vein when you have an anaesthetic, regardless of what we do. But in the emergency department, that might not always be so straightforward. So they have this availability and ease of administration thing. But there are some alternatives available. And this is a thing called methoxyfluorine. or penthrox, this little green jobby you can see just here. And again, that's a gas that you can breathe in, and it's a painkiller, but it's much less of a greenhouse gas than nitrous oxide is. So emergency department colleagues are starting to think about alternatives that they might be able to use. And then the next slide, please. But I think the really tricky thing is in maternity. And the reason for this is that if you use an alternative to nitrous in maternity, it comes with a lot of baggage. So one of my jobs, as I said, I'm an obstetric anaesthetist, and I do things like epidurals, and we also offer remifentanil to patients who would prefer something stronger than as a pain relief. Now, if I do either one of those things, the patient has to be closely monitored. They have to have something monitoring baby's heart rate. They have to have a midwife close by, and they need to be on a consultant-led labour unit. They need to have intravenous access, and they need to have an anaesthetist involved. So that does a few things, doesn't it? It increases the amount of resource that's needed to provide pain relief to this patient, but also it takes something from being a natural process with some nitrous oxide to all of a sudden being very, very medicalized. And a lot of patients, that's not what they're looking for in their delivery experience. So I think this is the real challenge. How do we get rid of it from maternity? Just as a footnote, methoxyfluorane, penthrox, like in the emergency department, that has been used in maternity. Some small studies have indicated that it's potentially feasible, but what we don't have is 150 plus years of experience saying that this is safe for mums and babies. And nitrous is so embedded in maternity practice that they'll take a cylinder of Entanox, even if you're having a home birth, and give it to you there. So I think for me, this is the real challenge, where it's difficult to swap nitrous oxide out. Next slide, please. So this brings us kind of onto the emissions things. And at the moment, if you have nitrous oxide and you're in the UK, you breathe it in, you breathe it out, and it disappears off into the atmosphere and acts as a greenhouse gas. If you don't breathe it in, but it gets wasted in some other way, either because we're giving you too much or because it leaks from somewhere, likewise, it ends up in the atmosphere. But if we look over to the Nordic countries, they've started to do some really important leadership work on this and decided that that's not acceptable. I have to say I agree with them. And there's technologies that have been implemented there and that we're trying to evaluate here as well, that look into how to break down nitrous oxide, to turn it back into nitrogen and oxygen, which don't have those greenhouse effects. So there are ways, even if you have to use it, to address some of its environmentally harmful impacts. Next slide, please. So in summary, and if you could just click through these one at a time, we've got this historic attachment to nitrous oxide, and it's really difficult to wheedle something out of clinical culture. Next one. It is a good drug. I think we have to accept that it has some useful qualities, and that's why it's been with us for nearly 200 years. But it's not good for everything, is it? It's not brilliant for patients when you really look at it, and it's really bad for the environment. And I'm really quite disturbed about some of the things that we might be exposing our colleagues to as well. There are some replacements, and I've talked about some of those very briefly, but they're not all straightforward. And I think the case in maternity is a good case in point to demonstrate why this might be quite a challenge, and therefore it requires innovation. And I think probably that clinical use might not be the biggest problem. So some of the early data that's coming out about things like cylinder returns and leakage is really worrying. And that might be a really important area for focus. So that brings me to the end of my talk. Thank you ever so much for having me along to speak. And I do have to leave a bit early, but I'll try and get some questions in at the end. Thank you.
That's great. Thank you so much, Cliff. Some very interesting messages and insight on practices as well for the use of nitrous oxide. And we'll come back to questions for Cliff in a moment. So please do feel free to pop them in the Q&A, and we can perhaps have some questions about practices or generally nitrous oxide and gases. Thank you, Cliff. So now I would like to introduce you to our next speaker in this session, Alexandra Hammond. Alexandra is the head of sustainable procurement and supply chain at NHS England and NHS Improvement. She has a range of public and private sector experience. She's led the development and implementation of activities to achieve a net zero supply chain since the report on delivering a net zero NHS was released. And in a previous role, Alexandra was leading on an award-winning sustainability program at Guy's and St Thomas's NHS Foundation Trust. Alexandra, welcome. We look forward to hearing about sustainable procurement. Thank you.
Thanks very much. I'll assume you can hear me unless I hear anything else.
Yes.
I just wanted to say what an excellent introduction and inspiring scenario Cliff's just set out. I mean, it's really fantastic for us who work in the kind of strategic policy side of trying to achieve net zero to see it in action, and it's really exciting to be part of this SBRI bid. We're really looking forward to seeing what comes out of the great ideas and the creative minds of the UK on this agenda. I've got a relatively short presentation, but just to give you some background on kind of what we're doing. We have a program, if you actually can move on to the next slide, please. Thank you. So we have a very clear mandate around net zero carbon. We are, as the NHS, acutely aware of our impact, becoming more aware of the detail of that impact every day through research and information that we're gathering. And we have a really urgent call to action here to make sure that we're ourselves reducing our impacts, but also enabling our suppliers and our suppliers to reduce their impacts. And this is a program that's been in train for a number of years, but the Delivering a Net Zero report that came out in October of last year really gave us some strong mandate. Gave us a really strong mandate on which to hang our program and the work that we're doing. Supply chain, it won't surprise you, is a huge part of the NHS impact on carbon. Over 60% of our carbon sits in our supply chain, so it requires even more urgent action than taking action at an operational level. And we're really working hard to make that happen. We also are conscious that we don't live in isolation in carbon. We need to make sure that we're taking care of our people and our communities as well. So we are very keen to make sure that what we're doing, Nick's mention of doing no harm, is reaches to the people that deliver our services, create our products, etc. So we have additional pillars of our program that cover modern slavery and social value, making sure that we are being the anchor institutions and taking care of our people in the way that we should be. Next slide, please. So this might be a useful slide for the breakdown of our supply chain emissions for reference. This is in the Net Zero report. Really the gray line at the bottom of the screen you'll see is our current supply chain emissions reduction, our baseline. We're looking at over 16,000 kilotons of carbon equivalent that sit in our supply chain. This is not a small ask, but we have a plan, and this is the exciting thing. So, the green bars that you see above represent the things we need to do and the activities we need to take in order to make sure that we get to our net zero goals. And I hope this is big enough for you to read on the screen, but I'll read out a couple that are really important. Pharmaceutical suppliers meeting their NHS commitments. I mean, the stuff that we're talking about that Cliff was just talking about, this is all so critical. Reducing single-use plastics, metal instrument reprocessing, something that actually saves the NHS money and carbon at the same time, which is a fantastic co-benefit. Looking at our construction, this is a very wide-ranging agenda, and I think it's really exciting to think about the innovative things that can be happening along here. But I mean, I think the focus for this is really around clinical care, and it's really exciting to see what we may be coming up with as part of this competition. Next slide, please. So we have hopefully a quite easy to understand but powerful message around the circular economy within our program. What we ask is that we promoting, asking our suppliers to look at their products, look at their services, and think about what we call the 5 R's of sustainable procurement. You'll be familiar with 3 of them: reduce, reuse, recycle. We've been saying those a long time. They're critical. They're absolutely critical. The fewer materials we're using, the shorter the pathways of manufacturing, the better. But also we really need to focus on some of the other areas, things like reprocessing equipment, medical equipment, and materials within the NHS. There's a real opportunity, I mentioned this just a moment ago, around how we can look at materials that come into our hospitals as products, and how they can then be turned into something else, either the same product again, of exactly the same quality, or potentially even a repurposed product. And this is a really exciting area of development. And then also we add into those 3 R's plus the reprocess, we add renewable. So thinking about the materials that the products are made out of, but also, how are those products being produced, and how are they being transported? We really want to look at the whole supply chain here. We have a real emphasis in this competition on products that are made and manufactured in the UK, and this is a really important thing because it really cuts down our travel miles, but it also promotes the innovation and great brains and science that we have here in the UK. Next slide, please. So these are examples of some of the 5 R's that we've seen so far. One I think is really kind of an amazing one, was one from Great Ormond Street around gloves. This is a practice innovation, but it's basically clinical staff saying we're using too many gloves, we shouldn't be using so many, and using the power of the people to say, let's do something different, let's follow the proper guidelines, let's not over glove, and they had a huge reduction in their glove use. But we are also looking at really innovative things. We're keen to explore 3D printing, and bio-based polymers, and all of these things that can really contribute to a lower carbon and ultimately zero carbon supply chain for the NHS. Next slide, please. I think that might be me. Yeah, that's me. I've got a lot to say about our program. We're doing heaps around engaging our supply chain, and making sure that we're activating them to follow our leading and help get on board with the delivery of these net zero targets. If you want to know more, email me at the address you can see there. I really look forward to seeing the outputs of all of this good work. Thank you.
Wonderful. Thank you very much, Alexandra. That's really lovely to hear and gain a bit more understanding of what sustainable procurement looks like and what you aim to achieve, but also some of those examples that you've mentioned towards the end. So I think it just puts it a little bit more into reality, which is really lovely. Thank you. Okay, so now I think it's time for our Q&A session. So what I would like to do is bring back our 3 speakers, Nick, Cliff, and Alexandra. If you're able to join us, and we're going to go through some of the questions posted by the audience, and then see if we can address a few during this session. Right, so I'm just opening and then seeing what we've got here. And the first one is more of a comment, I guess, rather than a question. But it's a great call to action, Nick. So I think clearly, people are really supportive of what's going on. So we've got a question here. We have developed a disruptive technology to enable the sustainable management of clinical waste, eliminating waste miles, avoidance of incineration, reducing requirements for on-site waste handling and storage, and enabling generation of low-carbon energy for use in NHS facility. Would this be within the scope of the competition? So I don't know if it's something that you would want to comment on, Nick, regarding all those different aspects.
Sure. I guess I'd need to see the thing, and also not my call, right? We're gonna keep this as independent and as away from aberrant Australians as we possibly can. I suspect the answer might be no, not quite. It doesn't quite fit into the scope of what we've got there. What you must always follow that up with is there are going to be so many more of these. We're gonna be innovating in all sorts of different fun and wonderful and weird ways, and the woman, at least to my left, maybe to someone else's right, Alex Hammond, I'm sure has many ways of, gathering, collecting sort of interesting areas of innovation that are already ready for procurement, ready for purchasing, and looking at how we could start to pilot those. The thing I would sometimes say in the NHS, a new product like that is always best done, not necessarily nationally. Sometimes best trialed out a couple of places locally, sometimes best sort of demonstrating this works, overwhelming evidence so that, God, you can't not do it nationally.
Great, thank you, Nick. Alex, was there anything that you wanted to add on to that? Maybe any tips on how they can perhaps approach some of these innovation from a procurement point of view?
I think it's it's really about demonstrating that. Before I answer that, I would just on Nick's point, yes, there are lots of great technologies like this, and we want to hear about them. So please, do let us know. If we may already be aware of them. We are trying to gather as much information as we can, but we're really keen to know about your products. So do email. But the other thing I was going to say is that this opportunity is particularly care focused, which is fantastic. But really stick to the brief. I think is really important. I know it sounds a little obvious, but we have really thought through this brief to enable what we are trying to achieve across the NHS by improving the products that we use and the innovative technology that we take advantage of. So look at those 5 R's, look at the brief, sorry, the brief that's been published, and answer it very specifically, because it will help so much in our evaluation. Well, not our evaluation, but the evaluation to ensure that we are really letting your product shine as much as possible.
Great, thank you. And there's another question, perhaps is as a follow-on, is how will funding match the demand to support the adoption of innovations to reduce carbon emission? And I don't know if it's something Nick or Alex you wanted to comment on.
I'm happy to comment on anything. I'm not sure I fully grasp the nature of the question, though.
So is funding matching the demand to support the adoptions? I guess is how much pull is there to implement and adopt those innovations, and whether funding is going to match this pull, I guess.
The demand is get the directionality right. Is the NHS's demand for a net zero healthcare service matched by the NHS's funding to support a net zero healthcare service? Is that the question?
I believe so, yes. I mean, that's how I understand it too.
Okay, sorry. I'm a very simple man. Our demand is enormous, right? We aren't tweaking around the edges. We aren't just purchasing some renewable energy and saying we're done with it. We aren't doing the easy stuff. We are doing the hardest thing the NHS, I think, will have had to have done in its entire existence. We are reorientating healthcare, conceptually and from the ground up and top down and everywhere you look. Will there be enough funding to support that? Sort of not, right? There will always never quite be enough because the demand will be basically infinite. Why am I not worried by that? Because this is not just the direction of travel that the NHS is heading. This is the direction of travel. Off the phone with our friends at the Danish embassy in Sweden, in Canada, in Australia, Malaysia, Singapore. This is the direction of travel that the entire world is heading. It's not a question anymore. It's not will we, it's how quickly and who's ready, right? And so to that end, what we have behind us is the entire procuring power of the entirety of the NHS, right? and not just the NHS, the German healthcare system and the French and etc. So I suppose that's probably the way I think about it is, you know, from an NHS perspective, are we ready for the changes that the government are bringing in, that the world is heading on? It's the question back out to our suppliers and the people that we procure from. Are they ready? The world is changing. Does that make sense? That's my attempt to answer a question that I think I've poorly understood.
Yeah, and I think there was some follow-on that came through the chat.
Thanks, sorry.
Just let me find it again. It was something around basically where will the money come from to pay for the innovations. But I guess from your end, Zenik, is just, you know, is just supporting innovation, whatever. It's not about sustainable. It's just about the future of innovation. They're going to have to demonstrate sustainability.
I mean, I think that's right. Like, you know, let's be real here. Those questions that suggest, oh, this requires huge amounts of extra funding, and you know, we won't do it unless we're funded to do it. You'll be left behind. I'm sorry. You know, that world was the world we were living in the 90s. Cabinet has been very clear 2 or 3 weeks ago, right? The Cabinet Office turned around and said, central government, all contracts over £5 million, demonstrate how you're contributing, how you're going to get to net zero. That's the kind of thing I think we expect to see increasingly here. If you want to win that contract from them, that's what you have to do. Are there going to be things we need earlier, faster? Are there going to be things that are specific to healthcare that we need to intervene with? You know, absolutely. Do we need to work on this together? Absolutely. That's why we have competitions like this. That's why, Alex, you know, all the work you're doing, fantastic with the sustainable sort of supplier forums. That's why we're doing all of that as well.
Great, thank you. And I guess we've got questions for Cliff. So do we know the life cycle carbon dioxide impact of intravenous anesthetic drugs, including the raw material manufacturing element, in comparison to, sorry, my screen is moving, to volatile gases?
Yeah, so I can answer that one. So, I mean, let's talk about nitrous first of all, because that's what the focus is about. And I saw that question coming up, so I did a quick Google, and there's a colleague of mine called Jodie Sherman who's from Yale, and she's done loads of really cool work about this. So let's take remifentanil, which is the alternative for us as anaesthetists, as an example. I can see from one of Jodie's papers that if you make a kilogram of remifentanil, you'll emit about 100 kilograms worth of CO2. By contrast, so how long will a kilogram of remifentanil last you for? Well, we use about 1 milligram per hour. So we're on for about 1 million hours worth of anesthesia for 100 kilos of CO2 equivalent. What does a kilogram of nitrous emit? Well, that's about 300 kilograms of CO2 worth. And how long will that last us for? About 10 hours. So, you know, the factors are absolutely astronomically different, aren't they, for that kind of thing? Now, we're not including in that any of the kind of delivery stuff. So you need a pump to deliver your Remi, you need an anesthetic machine to deliver your anesthesia. And so these are back of a fag packet in the 10 minutes since that question came up type calculation. But we see the same pattern repeated again and again when you're comparing inhaled anesthesia to injected anesthesia. Now, injected anesthesia isn't completely benign. So anything you inject, the body either metabolizes it or it doesn't, and then it excretes it somehow. So you probably pee it out. And there are concerns about things like water toxicity with high concentrations of intravenous anesthesia. So coming back to Alexandra's really nice thing about, you know, reduction being the most important stuff, you know, perhaps the most important thing that we need to focus on is not doing operations that don't need doing and making people healthier rather than letting them get sick and then have an operation. But if you are focused on climate and you want to deliver a general anesthetic, I think the jury has come back and delivered a verdict about whether inhaled versus intravenous is better, in particular with regards to nitrous. So I think that you can read about that in lots of different papers, but all of them have the same direction of message. There are things you can do with technique to bring those things closer together, but it never seems to flip the other way around.
Very interesting. It's very important to consider the whole life cycle, isn't it? A follow-on question, actually, Cliff. Would it be useful to more accurately determine the dosage of nitrous oxide in maternity? Because this seems to be where volume reduction might be achieved. How is dosage currently determined? And somebody saying that anesthesia is something of a dark art.
Yeah, it's the darkest of the arts, I reckon. So what can we tell about that? So no, the dose isn't determined at all. So if I was to prescribe you some paracetamol, I'd write down that you can have a gram of that 4 times a day, and that's what you get. If I was to prescribe you some Entonox, I would prescribe it in such a way as to basically give the patient access to it, and then the patient has as much of it as they want. What we advise people to do, if that's what they want to use for their labour analgesia, is as soon as they start to feel a contraction coming on, they can start breathing deeply and slowly on the Entonox, and as soon as they can feel the contraction start to fade, they stop breathing. And I guess what you could do as a very rough rule of thumb is count the number of breaths that they take during that time, and the number of contractions they have in a certain period, and then you could try and sort of reverse engineer the dose from there. But there is no precise measurement, like there is in anaesthesia, about the amount of nitrous oxide that gets given in maternity. The other thing about gases is that it's not the absolute amount that's used, but it's the concentration of that gas within the lungs that determines its effect. So, the reason that we use relatively less gas in anesthetics is that we have what's called a circle circuit. And that means that the patient breathes out, it goes around a circle, gets the CO2 taken out of it, and then goes back into the patient. Whereas in maternity, they breathe it in and then they breathe it out into the atmosphere. So it would be useful for sure to know how much we're giving, because it's very hard to mitigate something when you don't know how much of it is being used. And there are lots of ways that you could think about reducing it, but at the moment in standard UK practice, we're using absolutely none of them, as far as I can see. When the decision is made to give nitrous oxide, it's handed to the patient and they regulate it themselves.
Okay, great, thank you. So we've got a questions on decision-making tools, and whether there's any thoughts about clinician-led tools or patient-led tools, or potentially within the space of shared decision-making and involving carbon use as part of the clinical decision-making process. Any thoughts on that? I don't know if Nick, any thought? I think because one of the category we've got in this competition is around tools for better, greener choices, both for the patient and for the clinician. So I think that's really sort of covering that aspect.
Yeah. Sure. Look, many thoughts. It's complex is the answer to that. The therapeutic space, I learned on day one of med school and every day since, is sacred. And a really, really important place. You got to be careful introducing things into there that ought not be there. So when it comes to decision support tools for patients, for clinicians, we have to make sure that what we're doing there is maximizing patient well-being. We have to take a broad understanding of that, though, right? Beyond just the immediate thing right in front of us that day, you need to consider the entire sort of ecosystem that patient's going to exist in. Often these things are very, very closely aligned. Often, actually, they're so closely aligned that there isn't quite the trade-off everyone is worried about. Where there's the trade-off, the patient wins. Let's be clear. Never say anything other than that. But I bet you'll find that 98% of the time there isn't a trade-off, and that remaining 2%, a bit of innovation will get you there. So very interested, very excited about the idea of those sort of decision support tools, clinician-led, patient-led, whatever it may be, but designed with that principle as the foundation and unwavering. Is that reasonable? Cliff, I mean, do you disagree? What do you reckon?
No, I completely agree. And so many of you will be aware that there's a concept that we sometimes call the triple bottom line, which is often talked about in sustainability. And you've got financial things, and you've got environmental things, you've got social things. And the way I conceptualize that in health is the social stuff is largely about the patient. And I think you've got to look after your patients, haven't you? That's why you get into the business. But there are loads and loads of examples where you can tick all three of those triple bottom line boxes and make patient care, better and cheaper and greener all at the same time. And so when I go talk to my medical students, we use inhaled anesthetics as a good example of that. And if you can save yourself, for example, a post-operative complication or an overnight stay, you've bought whatever it is that you've innovated to do, because unanticipated hospital admissions or intensive care admissions are the things that are financially and administratively really problematic for patients, as well as not being very nice.
Great, thank you. So I guess we've got a question on perhaps very specific problems that innovators could look to solve. There's a comment on your presentation, Cliff, that it was brilliant at showing the real problem that they can look to solve, particularly around nitrous oxide. But where can we find example of other problems to solve, and what are the major issues that we can concentrate on? And I guess Richard came as well with a second thoughts around asthma inhalers, which we know is a big issue. I was wondering if there's anything that we could provide in terms of where we are with asthma inhalers, Nick, and perhaps why we perhaps not looking at it at the moment in this competition, or potentially some other big challenges that people could focus on.
Sure. So how about I take the last part of that question, and then whoever else has something more informative to say, take the first part. Why are we not in this competition focusing on X? Because Net Zero Healthcare is absolutely everything. And if you're not careful, you might sort of ask for everything and not quite get what you need, right? So we're trying to be a little bit more narrow, a little bit more focused. This is just the first time we're doing this. We'll do it, or the third time or something. We'll do it again and again. We'll be back again and again, right? Specifically, why not inhalers? To be frank, because there are countries out there in the world that have an infinitely lower emissions profile with existing technology. Yes, there are innovations needed in that space. Yes, there's a lot of work to be done there on the recycling, on the sort of out the other side of the inhaler use. Yes, there's a lot to be done on the different kinds of accelerants and the different kinds of ways of delivering the medication. A lot of that innovation is already underway, but I'll repeat myself. There are countries out there already that have already reduced their emissions from inhalers, and so I think we'll follow their lead on that.
Right. Yeah. Is there any other comments around other particular problems or any? I think that the challenge brief is quite specific on what we're looking for this competition. So I would just and as perhaps Cliff, you wanted to add anything, really redirect people to the challenge brief, really saying what this competition will try to address.
Yeah, I think all I would say is, so the brief tells you the areas, doesn't it? But the clinicians are probably the people to speak to in terms of the applied stuff. So I've been able to set out what I think, from my personal perspective, is important about nitrous oxide. I'm sure you'll be able to find somebody to come and talk to you about care miles, if that's something that you want to focus on. Because it winds us up too, just like it, as clinicians, we don't like dragging patients around the country. We don't like moving stuff around the country. It inconveniences everybody. So I think as a top tip, get in touch with your local clinicians. We like talking to people about fixing problems. I don't think it'd be difficult to get somebody to compile a similar list of things that you could attack within a different area.
Thank you, Cliff. We've got a questions around going back to funding and government. Does government need to allocate specific funding to support the change program? So that's kind of quite high level, and perhaps some thoughts.
Yeah. It depends on the question of change program, but yeah, absolutely right. And I would follow that up instantly with and it is. There's £1 billion out there for the public sector to decarbonize the estate. The NHS, we've been pretty successful there, $250 million to the healthcare service, because we were ready, because we had a plan, because we put our hands up and said, hey, this is how we're going to do it, and we can do it tomorrow. Let's go. there is funding out there for all sorts of areas here. Is it enough? Again, no, never. Must we ever let there's not enough funding stop us from doing something? Never. Political science 101. People will always complain that there's not enough funding to do a policy, followed by the funding materializing, and then they'll shift to what they complain about. You can act on the vast majority of what you want to act on when it comes to a low carbon healthcare system without significant amounts of additional capital resource. Is that, I mean, Alex, you know, you're closer to a lot of the procurement side of this than I am. Do you feel that, or am I being a little too optimistic?
No, I think you are. You're absolutely right. I mean, I think what we have to keep in mind is that those that innovate in here and make their products scalable will be the winners, right? So we don't want to. Yes, there needs to be some seed funding. Yes, and that's what we're doing. We're putting in place the foundations and giving that nudge for those suppliers that are, you know, those designers out there who have great ideas. But we, you know, this is a competitive industry, and what we feel is that we have this collective huge purchasing power. If you can convince the NHS that the product that you have is the right product to use and it's affordable and it's scalable, then you're onto a winner. So I mean, to a certain extent, yes. And the government is putting a lot of money. I mean, the government's putting money into our program. We're here because there's commitment at an NHS board level to deliver on this agenda, and it's embedded into everything that they're doing. You know, so Simon Stevens is absolutely completely dedicated to this, as is his board. So there's a lot of support that is happening behind the scenes as well. So you just to give you that reassurance. And I think, you know, we will, as Nick said, there's more funding will come in different shapes and sizes, but really it's about finding the right things that stick, the technologies that stick and are scalable, and that's the really key thing.
Okay, great. Thank you, Alexandra. And is there any specific sort of tips or advice that we can give to innovators in terms of who they need to engage with for sustainable procurement?
I sort of, to a certain extent, I want to say me, but then I wonder if I'm maybe building a rod for my own back. I would say we as a team are at the moment working on our supplier ask and our wider sustainability program, how we decarbonize our supply chain, and we've got some opportunities to get involved with that. If supplier, you know, so we really want to hear from suppliers and prospective suppliers on that, and that will, you know, tell you a lot more about our program, the wider stuff that we're doing. So please email that england.p.tom sustainability. Apologies for the lack of for it not being a great memorable email address. But you know, please keep in touch with us, and you know, we do have supplier forums, we do have innovation panels and things. So we are, you know, we do want to keep in touch.
Okay, that's great. Thank you. We've got a question a bit more specific, Cliff, perhaps, on what percentage of the problem with nitrous oxide might be in the leaky pipes issue, or is this one of the late Donald Rumsfeld unknown unknowns?
So I think that's becoming more and more known. There is currently a project going on, which is being led by somebody called Chris Allen, who's the National Sustainability Fellow from the Association of Anaesthetists, and somebody called Alethea Shakera, who's a pharmacist from NHS Lothian. And they're doing something called the Nitrous Oxide Project. And we're all going and looking at the usage of nitrous oxide in our operating theatres, and we're looking at how much is being delivered to our manifolds, and we're trying to work out the ratio of what's used versus what's purchased. And I don't want to steal their thunder, because I'm sure they're going to make an announcement about this at some point, but the early data that I've seen coming through suggests that in some places the majority of nitrous oxide that is purchased is not going into patients. It seems to be very dependent on the facilities in question. So I can imagine that a really efficient system that's recently built and nicely leak checked and so on might not act like that. And an older system that's had, new things added on and old things taken away might be more likely to be like that. So I don't want to share data that isn't mine to share, but I don't think it's, I think it's now common knowledge that in some places, more of it is not going into patients than is going into patients. And that's a big worry, isn't it? I think if this was any other drug, if this was a drug we could see, and it was tablets of paracetamol being tipped into the street, there would be outrage about that. But because it's an invisible gas, it hasn't been and it's cheap, it's not been a big focus until these colleagues have started to shine some light on it. So they're doing absolutely fantastic work with that. We're contributing to that at the hospital where I work. I've just been reviewing our data this morning, and I'm really excited to see what is announced, because that's going to be fascinating, isn't it?
Absolutely, yeah, incredible. And then coming back to one of the previous question, Cliff, and some of the comments that you made, somebody asking, do you see the opportunity of improving patient care first, or you're concerned about the impact of the environment first? Do you talk to somebody and how you influence others on the importance of this work?
So I think there's probably some ground rules to this, isn't there? So patient care in the round and environmental stewardship are the same thing. So there is no point in wrecking the health of tomorrow's patients in the process of helping out today's patients. However, you can't make things worse for the patient in front of you either. So I think in terms of what I've done in my practice, or in working with my colleagues in Wythenshawe, is that we wouldn't be comfortable to offer an anaesthetic service that was worse than the one we were offering yesterday from the patient's point of view. We're really happy if we can offer something that's greener, that the patients don't notice. That's fine. We're super happy if we can offer something that's greener and that the patients feel is better for them as well. And if we can do that, that's cheaper also, then that's the big win, isn't it? So I think that triple bottom line is a really interesting construct, and it's what I've always got in mind when I'm thinking about these sorts of things. But I am not prepared to make care worse for my patients. I am potentially prepared to make something a little more expensive at the point of delivery, especially if I can justify it with savings somewhere else. I think that's fair enough, isn't it? And I would really like to make things greener. So I think you probably need to have a bit of nuance when you're interpreting how those three things interrelate. But the ground rule should be, clearly it would be, we wouldn't emit any carbon at all from anaesthesia if we just stopped doing operations. But that's not good enough. We need to, do the right operations to the right people. I need to do them in the right way. So I don't know if that answers your question, but I think you've got to you mustn't harm people in the process of doing this.
Can I, something that, and in some ways we should stop asking that question. Like, no one has ever said that ever, right? No one has ever suggested that should be a thing that anyone should do. There's something that, we started to realize very early on in the pandemic, mid last year. Everyone started saying, this is really interesting. There's an interesting discussion here. Emissions have fallen as we've all been in lockdown. And the immediate response to that must always be, well, not quite. What's happened is we have just stopped activity. So things have stopped, so emissions have stopped. That's not what anyone was ever arguing for. The thing we were arguing for was decouple carbon and growth, decouple activity and growth, decouple the provision of excellent healthcare from carbon, so that you can still provide the best healthcare in the world independent of the amount of carbon. And I think that's what we're looking for, right? That sort of decoupling, not necessarily just, getting rid of.
Great, Thank you. Thank you very much, Nick. So I think we're probably arriving towards the end of our first Q&A session. And I just wanted to thank you, Nick, Cliff and Alexandra, for joining us in this session. That was really exciting talks, presentation and insights. So really grateful for your contribution. I think we've covered most of the questions we received. But if there's anything to follow on, we'll put that into our FAQ, and we can always follow up by emails. And I think you've got some details to follow up with Alex's team and the Greener NHS program. So thank you very much to you for coming today. I really appreciate it. And I would like to now move on to our next speaker. And I would like to introduce you to Cathy Scott. Cathy is Director of Operations and Deputy CEO for the Yorkshire and Humber AHSN. And she has executive responsibility for ensuring that the AHSN delivers on its programme of work, including the management of the Project Management Office. Cathy joined the AHSN after a leading role within NHS England, Research and Innovation, where she was an integral part of the NHS England's management of AHSN. Cathy, welcome. Thank you for joining us today. Over to you.
Thank you very much. And I'll assume that you can hear me unless people start waving frantically at me.
Yes.
So I'm going to tell you a bit about the academic health science networks and what we do and how we support people who are successful, how we support the innovations that have been successful in SBRI. And it's possible that I might touch on some of the questions that were asked earlier around funding for uptake of innovation and also around who to engage with in the NHS, but we'll see. The next slide, please. So there are 15 AHSNs located across England, and we have a focus on driving the spread and adoption of health innovation, increasing economic growth, improving outcomes for patients and supporting SMEs and innovators. So each of us operates on a local level where we are designed to meet the needs of our local populations. So each of us looks very different. But we also work regionally, so collectively in our regions, and we work nationally. So we operate as one large national interconnected network of networks. So we can work together to spread insights, learnings, and innovation. So as I said, we're all about the spread and adoption of innovation. We share our learning, and this means that we're quickly able to identify potential solutions to the unmet needs in the NHS. Next slide, please. So we're able to achieve quite a lot of impact, given that we don't have a huge amount of budget. And we're able to achieve impact because we share a set of national commissioners and a set of priorities. So we have a shared mission that is around improving health, driving down costs and stimulating economic growth. And then we share a set of priorities which are around adoption and spread, support for the life sciences industry, including SMEs, as I said, local economic growth, identifying and promoting new technologies like AI and robotic process automation, and supporting research and evaluation to make sure that promising innovations are evidence-based, and most recently, supporting the environmental sustainability agenda. We strongly believe that you can't get the different results by doing the same thing, so innovation definitely plays a part in meeting the drive for net zero. Next slide, please. So I mentioned our impacts, and these focus on the industry and economic growth impacts because I'm guessing that this is what you're interested in, although we had significant amounts of impact on patients as well. So in the last year, we supported nearly 3,000 companies with over 4,800 of support, and that support varied from being very light touch to being really intensive. We created 700 jobs and we safeguarded a further 763. And we leveraged £462 million worth of investment into our local health economies. Next slide, please. In terms of how we do that, how do we support innovators? How do we leverage the income? How do we protect the jobs? We take a bespoke approach to each innovator and company that approaches us. So each AHSN, as I said, is slightly different. Each has a specific set of skills that are relevant to its local health economy and the organisations within it, and sort of special knowledge, if you like. So if you go to one AHSN and it doesn't quite deal with what you're offering, then they will probably refer you on to another AHSN that does. So we take a bespoke approach, but basically our activity falls into 4 areas. So we identify and communicate need. We work with the National NHS and with our local organisations to understand what's important to them, what the pressing problems are, and what would work for them in how those needs are met. We do a lot of signposting, so we connect innovators to the right people. That might be around procurement experts to talk about how you could get the best possible business case up and running. It might be around what's the procurement people's stances on environmental sustainability innovations and how you could approach them with the best chance of getting your innovation taking up. It might be that we would put you in touch with an ethicist like Cliff to talk about your innovation and find out whether it's something that they're actually interested in or whether it's something that is of peripheral interest. Getting that information early is really important when you're developing your innovation. We also support spread and adoption. This is bread and butter for us. So we support the spread and adoption of innovation through our connections into our regional footprints. And we can provide you with a lot of support and advice around the best way to do that. Again, this is a bespoke approach, so it depends on the innovation and it depends on the local context. So sometimes we project manage it, sometimes we make the connections and facilitate those conversations. It really does depend. And then finally, we do real world validation. So this isn't a long, drawn out randomized control trial, which are absolutely have their place, and I'm not knocking them at all. But for some innovations, what you need is to say, does this work in real life? Does it have the impact it's intended to? How do users find it to apply, to use? And again, that's been really well received by innovators. Next slide, please. So just thinking about making that real for you, and I wanted to touch on a couple of innovations that in Yorkshire and Humber AHSN we've supported over the last few years. So we've been supporting Upstream Health, who offer rigid care, for about 3 years now. So we've supported them from a very early stage. Rigid care supports carers and those they look after through new tech and through holistic support. So we provided the company with advice on their strategy. We provided them with connections into the NHS to talk about what was relevant to the NHS and to local authorities to talk about what was relevant for social care. We gave them a platform to talk about their product, and we provided access to learning and information through our innovator workshops. We then also provided our support and expertise in terms of reforming and refocusing their vision. And we supported their successful bids for phase 1 and 2 SBRI. So they were successful in that, which was great to see. Next slide, please. We also have been supporting for around the same amount of time, 3 years, a company called Healthy.io, who do smartphone self-care for people with diabetes. So it's a tried and tested clinical grade technology which enables a COVID safe service, and it provides outcomes for at-risk populations like people with diabetes and hypertension. So we've been supporting them since 2018. We supported the evaluation and the regional adoption of specifically one of their innovations, which is a smartphone-based urine analysis device, DIP.io, and that enables home testing with no quality compromise at all. So we supported the implementation across one of our patches, Hull, Airedale and Wharfdale, and that's, I'm not going to be able to say these words, and that's for the detection of albumin urea, which is a sign of kidney disease in people with diabetes. And this is really important because there are 8 different case checks that people with diabetes need to go through every year, and the albumin case check is one of the lowest, has the lowest uptake. In COVID, it dropped to 16% of people with diabetes taking up the opportunity to have a urine test. When we rolled it out in the Leeds area, that increased up to 88% of people taking the opportunity to have that test at home. We also commissioned an economic evaluation cost effectiveness model, which compared the self-screening test against standard care. And that was really important in terms of getting the NHS to take up the innovation, because it showed that there was a cost saving and a time saving. It evaluated cost savings of £472 per patient over 5 years, which doesn't sound like a lot, but when you think about the number of patients with diabetes, it really is. So having rolled it out in Hull, Airedale and Wharfdale, it's now being rolled out across the Leeds City region area. And that was following a successful application to NHSX for additional funding, which again re-supported. So that's a couple of examples of how we actually go about supporting innovators and SMEs. but you're probably interested in what impact that has. Next slide, please. So these diagrams demonstrate the impact that the AHSN network has had on products where we have been funded by NHS England to deliver the uptake. So HeartFlow creates a 3D model of the coronary arteries, and that helps clinicians rapidly diagnose artery disease without the need for an angiogram, which is quite invasive. So they take the CT scan and apply the HeartFlow model. In March 18, we had no involvement. In April 18, it was put onto the Innovation and Technology Payment, which AHSNs were funded to deliver. And you can see that there was a real upturn in the amount of uptake that we had when we went through. We spoke with clinicians, we spoke with trusts, and we persuaded them to take up the innovation. So 17,000 patients have benefited since April 2018. 6,000 of those have benefited in the last year. Next slide, please. PLGF-based testing. So this is a blood test that helps predict the risk of preeclampsia quickly so that pregnant women receive the most appropriate care. And you can see the same story when AHSNs got involved around June 2019. The uptake, the spread really increases quite quickly. This one I'm particularly keen on because it keeps women out of hospital. If they have a low risk of preeclampsia, previously they would have been kept in anyway because we wouldn't have known it was low risk, and you're kept in hospital just to be on the safe side. But they can go home to their families, and because we're not keeping people in hospital, it has an environmental impact. So we estimate that in England over the last 2 years, it's avoided around 1,000 cubic tons of carbon emissions. Right, so just the final slide. So you've heard this from Nick's great presentation, and I've said already that we think innovation has an important role to play. AHSNs were name checked in the Net Zero report, and we're already fulfilling that task. We've been working on this for just under a year now, and we have a strategy that we've developed to look at what AHSNs can do to support this particular space. So we're reducing our own carbon footprint, as you'd expect. We're encouraging innovators to think green. So where people come to us with their ideas that aren't specifically about the environment, what can we do? How can we work with them to help them reduce their environmental impact? We're supporting the adoption of innovation with a positive impact. So where things are specifically about the environment, like the innovations that will come out of the SBRI call, we're working with them to increase their reach into the NHS and to get the uptake. And then we're spreading good practice and brokering relationships from other sectors. It's very easy to assume that if something has if something comes from the automotive sector or I can't think of the word I want, aeroplanes, that it has no relevance for us. But actually in the last few days, I've found stuff with a whole load of relevance for the NHS that we can pick up and lift and shift. And through this, we want to be able to influence national and local policy on support for and uptake of green innovation. So I've talked a bit about procurement already. We influence the NHS supply chain to take up some reusable PPE, which is a project, a pilot that we've been doing over the last year with COVID, looking at reusable PPE. And we want to create a movement across NHS staff so that they are fully engaged in this agenda. And as Nick said earlier, that there is loads of energy around this space. We want to try and capture that and get a real community going. And finally, we want to articulate the difference that we make to this agenda. We want to be funded specifically for this agenda. I don't know whether Nick is still here and listening, but you know, we can only do that if we show that we really make a difference. So all of our innovations that are funded nationally, we now put them through an environmental impact assessment before we start the work on them. And we're encouraging AHSNs to do that locally as well. So that all of our programs, you should be able to articulate what benefit it's had. And where it doesn't have a benefit, we work with the innovators to make sure that they change what they're doing so that it does, as I said earlier. So I hope that was helpful. Thank you very much.
Thank you very much, Cathy. That was really interesting. Thank you for discussing about the support the AHSN provides to innovators around the implementation of innovation, but also the sort of signposting and also some quite interesting case studies. So that was really good to hear. Thank you very much. And we'll go back to questions afterwards. We'll discuss first with Amy about the program's assessment process, as well as the application process to apply to this competition. So Amy is a senior program manager in the Innovations team and the SBRI Healthcare Program Management Office. And I'll hand over to you, Amy. Welcome. Thank you.
Thank you, Fanny. That's great. So I just want to provide you with a brief overview of the SBRI Healthcare application and assessment process to support future applicants applying to the Delivering a Net Zero NHS competition. So the process begins by companies and organisations applying to the competition with creative, innovative solutions to the challenges we have presented. Applicants submit a short application form for funding of up to 100k over 6 months, and these are then reviewed by a pool of experts covering clinical, technical and commercial expertise, and up to 25 applications are shortlisted. Following this meeting, shortlisted applicants are invited to submit a video pitch to support their application. These are presented to and reviewed by the selection panel, who recommend applicants for phase 1 funding. Typically, decisions are communicated shortly following this meeting. Due diligence then takes place and contracts are issued to successful applicants shortly after. Applicants that have been successfully awarded phase 1 funding can then apply for phase 2 funding of up to £1 million over 12 months to continue the development of testing of their innovations. Phase 2 funding is not guaranteed and is a competitive process, and applications are subject to external peer review, and then applicants are invited for interview and Q&A at the selection panel. Once again, outcomes are communicated shortly after the meeting and due diligence and contracts are issued. Next slide, please. Phase 1 applications will be reviewed by a selected panel of experts who provide feedback on the applications according to the following assessment criteria. So this criteria includes how the proposal meets the challenge brief, the design and deliverables of the project plan and risk mitigation strategies, the suitability of the commercialization and implementation plans, carefully considered PPI plans, the equity of access to the solution, and the strength and expertise of the project team to deliver the research. In particular, applicants applying to this competition will need to clearly outline in the how this proposal meets the challenge brief section of the application form, how the supply chain will be considered in the development of their proposed innovation, including how it will address one or more areas of the 5 R's of sustainable procurement, which were touched on earlier, and how carbon emissions will be managed at each stage of the product life cycle. Additionally, we're asking for a detailed methodology and framework outlining approaches to assess any reduction in carbon emissions resulting from the innovation, and relevant reductions elsewhere in the system will need to be provided. And there will be an opportunity to build on these plans in the submission of any phase 2 application. Next slide, please. To give you an idea of the success rate so far, across the 17 competitions run to date, we have assessed around 2,400 applications. Of those applications, around 10% have been successful in receiving phase 1 funding. And of those that were funded through phase 1, around 50% progressed through to phase 2. This emphasises that it's a competitive process and that addressing the assessment criteria comprehensively is really important. Next slide, please. To provide a brief overview of the actual application process, once you go onto the SBRI Healthcare homepage, which is shown on the screen now, you can access the open competitions by selecting the Open Competitions and Challenges tab. This will take you through to the competition page where you can find details of the Delivering Net Zero competition. Next slide, please. Once you click through to the competition page, you will find a lot of supporting materials available to help you navigate the submission process. These include the invitation to tender, the application and portal guidance, the challenge brief, which outlines all the challenges that were discussed earlier in the presentation, a template application form, and a frequently asked questions section. And just to reiterate, the key dates for this competition include the launch on the 15th of July and the application deadline on 25th of August, and the others are outlined there. Next slide, please. When it comes to submitting an application, this is done through the online application portal. Applicants need to be registered on the research management system to apply, and any first-time users will need to register. And this is described here to help you through that process. Next slide, please. Once logged into your account, you'll have access to the homepage where you'll be able to create applications, access applications where you're co-applicant through the Co-Applicants tab, and update contact information and professional details. It is worth noting at this point that any contact information entered during registration will be automatically transferred into the relevant fields of the application. Any changes to these details can be made through the Manage My Details tab on the left-hand menu. To start a new application, you will either find a link under New Grant Application on the homepage as shown, or you can go to My Applications on the left-hand side and click on the New Application button. Next slide, please. This will show you a list of open funding rounds and further information about the competitions. Once you find the correct competition call and category, you can then select Apply to open an application form. Next slide, please. From there, you'll be directed to the application summary page, and different sections of the application can be accessed via the list of hyperlink buttons on the left-hand menu. Most questions have help buttons that provide brief guidance notes, but as mentioned before, there's also an application and portal guidance document available on our website for further information on how to complete these sections. You will be prompted to save your work if you leave the browse and editing mode. We recommend that you save your work regularly and that you can save and return to the application form as often as you like prior to submission. Next slide, please. If you are a team member or project partner involved in the application, the lead applicant will need to invite you as co-applicants to the team section of the application form. Next slide, please. Once invited, the project partners receive an email to confirm their participation in the application, and they'll need to log into the portal and go through the My Co-Applications link to confirm their participation in the application. They will then be granted access to edit the online application form. It is important to note that all project partners must also approve the application before the submission deadline, which they can also find on the summary page. Next slide, please. Once the application form is complete, it must be validated before submission. There is a check to ensure that all mandatory questions have been completed. Once the application has been validated successfully, the lead applicant can submit the application to us. Next slide, please. So this is just a brief overview of the application process, which I hope was helpful. And if there are any questions, please do submit them to the Q&A, which we'll have after this, or contact us and the team here following the webinar. We can talk through these more clearly with you. Thank you.
Great, thank you very much, Amy, for covering the program's assessment criteria and application process. So now what I would like to do is to invite Cathy back, as well as Katerina Lombardo and Randa Tajdin from the SBRI Healthcare Program Management Office. And we'll go through some of the questions that have been posted in the Q&A box posted by the audience. So if you do have any questions, please do put them in the Q&A and we'll answer to them as we go along. So one of the first question is, I guess it's a bit of a tricky one, is around life cycle analysis tool and whether there's any suggestions the applicant can use to measure potential carbon footprint reduction. And we've put some example in the brief just to sort of give some guidance. But it's also recognizing that category 4 of the competition could support the development of new ones. So I don't know if there's any thoughts on that, if you've got any thoughts on that, Cathy. So we've provided a few links on carbon calculator, but obviously some innovations may not have something that quite fits with those current calculator. So whether there's any suggestions or sort of life cycle analysis tools when you've been working with some innovators. Cathy, you're on mute.
Yes, protection has been that often the tools that are out there are quite complex to use. And you need quite a lot of information to be able to put in. But let me take that back, and if the I can presumably send the response over to you, Fanny, and you can pass it on to the attendees, and I'll see if I can find anything.
Absolutely, yeah. Thank you, Cathy. And I think anything that is perhaps a bit more project specific or innovation specific, we might be able to answer into more details, either our webinar next week that will deal with clinics, sort of one-to-one sessions, but also by emails. If there's anything that we can follow up on or ask advice from the Greener NHS team, then we can take that back and respond to you. So we might be able to do that. So we've got a question about the total funding pot for this call. And Katerina, I was wondering if you wanted to comment on that.
Of course. Thank you, Fanny, and hello, everyone. There is not a particularly dedicated funding pot for this call because SBRI Healthcare as a program receives an overall funding envelope every year, and we dedicate it to all the activities that we support during the financial year. And in particular, as you might be aware, we have in parallel launched a call on stroke for this competition 18 as well. So we will be looking particularly at funding more projects according to the quality of the applications, not really in relation to the overall funding pot that is dedicated to each theme, if that answers your question. So try to put forward a strong application. The quality is the first thing that we look at.
That's great. Thank you very much, Cathy. Another question, can an applicant submit multiple applications, and what limits are there on combination of applicants, co-applicants and subcontractor? Randa, perhaps you wanted to take this one on, I thought.
Yeah, thanks, Fanny. So in terms of the number of applications you can apply, there isn't a limited number in terms of, if you want to apply to the different categories, you are welcome to do so. But it's just bearing in mind that you will be chosen for only one category if your project was awarded. And so because, we do appreciate that there is an overlap of the different categories in terms of where it can apply into reducing the carbon emissions across all 4 challenge areas. But it's just important to make it clear within your application form what exactly your technology is going to be tackling and where you see it most fit. So we would recommend that you choose the most appropriate category that you're trying to address. But if, as I mentioned, if you did have kind of overlapping ones, you can apply into the different categories, but you would only have one funded project if it were to get funded. And there was a question you mentioned about subcontractors. Can you repeat that, Fanny?
Yes, absolutely. So it was whether there was any limits on when they apply on combination of applicants, co-applicants and subcontractors. So I guess it's all interrelated.
Yeah, so again, with team members, subcontractors, collaborators, there is no limit on that. It's just making it very clear within your application form in terms of inputting that information in the team member sections. And again, whichever application is taken forward, if you were to submit multiple applications, it would be that one that is funded that goes through.
Great, thank you very much, Randa. That's really useful. I guess I had a questions on the support to innovators, Cathy, and I was wondering if you've got any tips for innovators when they want to get that sort of support, signposting, engagement with stakeholders or key opinion leaders. What is the best way? Is that the best way they start to engage locally with their local AHSN, and then you can signpost them? Is that how it works?
Yeah. So come through to your local AHSN in the first instance, and we will help you with that. The stuff that we give most support to is the stuff that meets the needs of our local health economy. So we could signpost you onto other AHSNs, as I mentioned, but we will be honest with you about whether or not it meets the local needs. It's not as relevant, that particular statement isn't as relevant for this call as it would be for, say, if you live in Humber Coast and Vale and you've got it's about stopping smoking, that's a big issue for them. So we would prioritise that over something that was about obesity, perhaps. But for environmental sustainability, that's an issue for all of health. It's an issue for all of the AHSNs, so you should be able to go straight to your local AHSN and we will support you.
That's great, thank you very much. So we've got another questions that came through. So product design engineer, and then so this team is not manufacturing anything. Is there a system by which we can be partnered with others to develop potential solution through a joint application? And perhaps that's something that you could comment on, Cathy, whether there's any help that they can find to partner applicants together.
That's a really interesting question, actually, and we don't specifically matchmake like that. That doesn't mean that we haven't done in the past, but it would depend on the proposal, the innovation, and so on. It's worth a try. If you've got something specific, go to your local AHSN and see if they can suggest anything. Most AHSNs will have on their website an innovation exchange, and within that you'll be able to see what innovations they are supporting at the moment. So if there is something that matches the ideas that you have, there is nothing to stop you from approaching that particular company and seeing if they would be interested in working with you.
That's great, really helpful, thank you. Because I think we've got a further questions perhaps on the application process, perhaps back to you, Randa. Just to clarify, can someone be a prime applicant on a funded project and a co-applicant on someone else's funded project?
All right, okay, so that's, yeah, a good question. So I think it would be more a matter of understanding what your capacity would be. So that would be something that would be looked into when the application is being assessed in terms of your role in both projects and how much time is committed into those, and whether we think that you know, if you are, you know, if you do have a role in both projects, which is quite substantial, whether or not it would be manageable to undertake both projects simultaneously. So that is something that will be looked into, but I don't think it's a exclusion criteria that we have, but it's just something that we would consider when we're assessing the application.
Absolutely. Great, thank you, Randa. So I don't think we've got any more questions coming through. If you've got any last burning questions, now is the time. Otherwise, we'll close the session in a moment. As I don't see anything coming through, what I would like to do is perhaps draw close to this session. And if there's anything that it comes a bit later, or any other questions that come to your mind, please do send us an email on our general inbox. And we'll also be responding to quite a few of those questions that came through in our frequently asked question document that we will put on our website. So we'll follow up on anything that is perhaps a bit more project specific. The SBRI Healthcare PMO will be holding a question and answer drop-in clinic where you could have the opportunity to have one-to-one session with one of the members of the Program Management Office, but also the Greener NHS team will be here to support and answer any of those questions. So our next webinar will be on Thursday, the 15th of July, between 1 and 2:30 before I say anything wrong. So that's our next sort of session, clinic, to answer specific questions. Quick reminder, the competition will open on the 13th of July and will close for application on the 24th of August. I would like to thank you all today. A massive thank you to our speakers, Nick, Cliff, Alexandra and Cathy, for joining us, contributing to our session, to this particular competition. Really grateful to have had such an insightful contribution today, and some really good stories and you know, sort of views and practices. A massive thank you as well to the Greener NHS team for coming and supporting us. And thank you all for attending this webinar today. We hope you found it useful, and we look forward to hearing from you soon. Thank you. Have a great day, everyone. See you soon. Bye-bye.